Hello everyone, my name is Jacob Klees along with Micah Brown, Katie Wong, and Abbie Parmenter. We are Masters of Public Health students at Florida State University. Today, we are trying to address the disparities in access to healthcare in rural areas. According to research, these discrepancies arise due to geographic isolation, lower socioeconomic status, higher rates of health risk behaviors, and limited job opportunities. The research also states that higher rates of chronic illness and poor overall health are found in rural communities when compared to urban populations. In this video presentation, we are proposing 3 solution options to improving access to healthcare in rural areas. The 3 solution options we have chosen are financial assistance for all medical providers practicing in rural areas, APRN and PA autonomy, and increasing the scope of rural residency programs at the state and/or federal level. Research shows that these 3 solution options mitigate the issue of limited access to healthcare due to medical provider shortages in rural areas. Each solution will be evaluated on the criteria of effectiveness, equity, both horizontal and vertical, stakeholder support and opposition, and political feasibility. Each criteria will receive an individual ranking out of 5, and the solution option as a whole will be ranked out of 20. The first proposed solution is financial assistance for medical providers in rural areas. This generally occurs through loan forgiveness, scholarships, and loan repayments for all medical providers, such as physicians, APRNs, PAs, and other medical professionals.
Hello everyone, my name is Micah Brown and I'm going to guide you through financial assistance in rural areas. The first step for this is covering effectiveness of the solution. Currently, there is an unequal distribution of medical providers throughout the United States. Using physicians in Florida as an example, presently there are 25 physicians per 10,000 people in metro areas and 8 per 10,000 in rural areas. Rural populations have unique healthcare needs and barriers to healthcare access due to provider shortages. The Health Resources and Services Administration, or HRSA, has placed over 1,700 medical providers in approved rural areas using financial assistance as an incentive. This is taking place through programs called the National Health Service Corps, or NHSC, and the Nurse Corps Scholarship. This solution has medium effectiveness as it does provide access to healthcare providers in rural areas, but the amount of clinicians taking advantage of these programs are relatively low, and many do not remain in the mid to long-term time frame past their program obligations. In regard to horizontal equity, this proposed solution will attract higher numbers of healthcare providers into rural areas by easing the financial burdens placed upon them, thus giving rural populations increased access to care. Funds could also be directed to areas with the most severe shortages or areas of high need and specifically used to target vulnerable populations with these rural communities. From a vertical equity standpoint, these programs are generally funded in a variety of ways. For example, scholarships, grants, loan forgiveness, etc. Ultimately, a majority of funding would come from general taxation. Many states have state-appropriated funds for loan forgiveness and repayments for providers working in rural health. Since rural areas tend to be poorer than urban areas, funding through general taxes will result in those with greater ability to pay allocating funds to those with the decreased ability to pay and with higher need. There are high levels of support for this proposed solution. For example, the American Hospital Association, AARP, the American Academy of Family Physicians, and many other stakeholder organizations support this measure. Our research was unfortunately unable to find any opposition to this proposal from stakeholder groups, though. Issues come into play in terms of political feasibility due to the integration of these programs into the Affordable Care Act reform bill that was passed in 2010. This leads to opposition at the federal level, generally with Republican politicians or those who are against the Affordable Care Act. At the state level, there is generally bipartisan support because its benefits greatly outweigh any potential problems with it. In order for it to be passed at the state level, there would have to be a bill proposed. And the biggest issues at the state level would be having the proposal pass congressional budget committees because allocated funding could be problematic.
For financial assistance for all medical providers in rural areas, we scored this solution option as a 15.5 out of 20. We believe that due to the high equity and stakeholder support of this option, this could increase the amount of medical providers in rural areas. Improving their retention rates of these medical providers and allocating funds to the budget would elevate this solution option even further. The next proposed solution is autonomous APRN and PA providers in rural areas.
Hi, I'm Katie, and I'll be talking about the APRN and PA autonomy in rural areas. This solution has high effectiveness because it will increase the number of healthcare providers in general, but specifically in rural areas. This solution would potentially widen the scope of the number of providers in which citizens of rural areas can visit. APRNs and PAs can also help to provide more efficient care, especially in areas where there are shortages of MDs. According to research in 2015, physician assistants care for a higher percentage of patients with public or no insurance as well as the medically underserved. In terms of horizontal equity, allowing for autonomous primary care providers will expand the opportunity to access medical care in rural areas. This would fill in the gap in healthcare access for these rural communities by increasing the number of primary care providers these patients are able to see within their areas. However, since no money is involved, it cannot be guaranteed that independent practitioners will go to the areas with most severe shortages and worst consequences. As for vertical equity, the cost implications of this plan are more difficult to calculate. Fewer doctors will be needed, so costs could be reduced based on care provided and competition added. In other words, patients would save money potentially because they would not be billed the cost of a doctor's visit. Alternatively, this plan would involve hiring more APRNs and PAs and therefore could cost hospitals and businesses more money, which could drive the total cost back up, though there might still be a lower on case-by-case basis. Further research would be necessary to prove that extra spending would be valuable in health status improvements. Next, for stakeholder support, the American Association of Physician Assistants supports PAs working independently of doctors, stating, states should consider eliminating requirements for rigid collaborative practice and supervision agreements between physicians and their care extenders that are not justified by legitimate health and safety concerns, and that PAs should be allowed to utilize their full skill set and bill patients appropriately. The Kaiser Family Foundation and the American Association of Nurse Practitioners have argued that MPs could help meet the demand for primary care. As for opposition, some people believe that PAs and MPs are not able to give the same quality care as MDs. One article states that they see less patients in an hour and they have poorer health outcomes related to their abilities to diagnose illnesses. They believe that MPs already have too broad of a scope of practice and need even more MD oversight. But the proposal would be fiercely fought by physicians who will likely use campaign contributions and lobby spending to fight it. The AMA passed Resolution 214 in 2017. The resolution calls for the association to create a national strategy that would effectively oppose the continual nationwide efforts to grant independent practice to non-physician practitioners. The AMA argues that nurses are critical to the healthcare team, but there's no substitute for education and training. As for political feasibility, the Florida House Bill 821 and the Senate Bill 972 are both currently being processed with a high possibility of being passed. This could be the start needed to get this bill to be passed through the rest of the United States. This bill currently being reviewed would allow APRNs and PAs to work independently of MDs. In the Senate, the proposed bill has passed the Health Quality Subcommittee 10 yay and 3 nay, and the Healthcare Appropriations Subcommittee 8 yay and 2 nay. It is currently in the Health and Human Services Committee as of March 29, 2019. The Florida Medical Association opposes this, but the House Speaker, Jose Oliva, wants to try to lower healthcare costs and get rid of unnecessary regulation. He states that Florida is behind the curve because it doesn't allow nurses to practice to the extent of their training. Senate President Bill Govano has said that he wants to make sure we are listening to our doctors in terms of what they see in the system. The Senate President is less on board than the House Speaker, but the bill already has quite a bit of support.
In regard to autonomous non-physician providers in rural areas, we scored the solution option as a 16.5 out of 20. This was due to high levels of effectiveness, equity, and political feasibility, in part due to the fact that these are current bills being passed in the Florida House and Senate, which puts the solution one step closer to implementation. Getting this support of physicians in the AMA would dramatically increase the stakeholder support and boost this option even further. The final proposed solution is increased rural residency programs in rural areas.
Hi, I'm Abby, and I will be discussing the rural residency programs for medical providers. We found this solution to be very effective. The Rural Health Research Center found that from a pool of 197 physicians, 38.1% of graduates of a rural residency program worked primarily in a rural location 1 to 7 years after graduation. They also found that 71.5% of all graduates were still practicing in the same location that they had completed their residency. Another study looked at the overall number of doctors and the distribution of residency slots, and they found that if current numbers of graduates continue, the non-metropolitan family practitioner general practitioner to population ratio will increase 17% by the year 2020. They also suggested that more people are pursuing DOs and that this will help more providers go to rural areas since there will be an overall higher concentration of healthcare providers. There are a lower concentration of doctors in rural areas, and programs like these would bring doctors to where they are needed. Their goal is to be sustainable in the long term and continue to bring in new doctors. In terms of horizontal equity, opening up residency programs among all medical providers, including MD, DO, APRN, and PAs, in these rural locations would increase the amount of practicing providers to treat patients. This closes the gap in healthcare access in more rural areas by bringing in more providers per patient geographical area. In terms of vertical equity, according to the AAMC, residency programs and teaching hospitals are largely funded through the federal government. There is currently a cap on the funding and the amount of training positions available. To increase the number of medical providers in rural areas, the cap potentially could be raised to those training in those rural areas. This would increase costs, but alleviate the shortage of medical providers. Overall, this solution had quite a bit of support. The Health Resources and Services Administration provides a lot of support for rural residency programs. They provide grants giving technical assistance to entities in order to establish these programs. The National Rural Health Association and the American Hospital Association also support the implementation of rural initiatives such as this plan. Many hospitals also have rural health programs that encourage their students to get involved in rural health care. Most bills relating to rural residency programs tend to have bipartisan support. For example, S304 is a bill that would go further, authorizing adequate and sustainable funding for existing residency programs and supporting expansion into rural and underserved communities. This bill was sponsored by Senators Shelley Capito, a Republican of West Virginia, Susan Collins, a Republican of Maine, Doug Jones, a Democrat of Alabama, and John Tester, a Democrat from Montana, and overall it had strong bipartisan support. We were not able to find any groups that strongly opposed this solution. With the closure of many rural hospitals and health centers across the United States, this initiative could go together or in tandem with addressing this issue in policy, or it could be completely overshadowed by more pressing issues. Many of the stakeholders that would be pushing the issue of rural residency programs for health professionals have a greater focus on addressing the closure of those rural hospitals and health centers. With generally lower levels of coverage on this issue, it puts less emphasis politically on this policy. After addressing the closure of rural hospitals and health centers, there may be more of a push by those in politics, advocacy groups, and stakeholders.
As for increasing rural residency programs for medical providers, we scored this solution option as a 15 out of 20. This solution has high effectiveness and stakeholder support, but low political feasibility due to a shift in focus. The focus is more on the problem of rural healthcare facilities closing, which means these providers do not have the fiscal means to practice in these rural areas. This is a comparison view of the rankings for each solution option by the 4 evaluation criteria of effectiveness, equity, stakeholder support and opposition, and political feasibility. This helped us determine which solution option would be the best to increase the access to healthcare in rural areas.
Based on our research, we argue that all 3 of the solution options are sufficient for solving the problem. Additionally, we believe that implementing all options presented would be the best case scenario. But in reality, due to the various factors, this would not be practical. Therefore, we decided that increasing APRN and PA autonomy in rural areas is the best solution for the problem of access to medical care. We based this decision on the criteria of effectiveness, equity, stakeholder support and opposition, and political feasibility. Thank you for watching. For more information on public health topics, please like, share, and subscribe to our YouTube channel. Go Noles!